Nayar, a consultant in HOD Akasha IVF Center, New Delhi, and he will be enlightening us on the topic Insulin Sensitizer in the Infertile PCOS. Welcome, Dr. Nayar. Please go ahead.
Good morning. My topic is Insulin Sensitizer in Infertile PCOS. PCOS is a global prevalence, almost 26%, but when we look at India, almost 36% women in India are suffering from PCOS. And PCOS is a heterogeneous syndrome. You have menstrual irregularity, 70 to 80%, you have hyperinsulinemia, and you have insulin resistance, 50 to 70%. And insulin resistance is what is giving us metabolic syndrome, leading to diabetes, hypertension, cardiovascular disease. The Polycystic Ovary Syndrome, there is increase in the weight, increase in insulin resistance, increase in the irregular periods, and there is oxidative stress. Insulin resistance is the primary cause in PCOS. And this is how insulin resistance works. When you have hyperinsulinemia, the sex hormone binding globulin is decreased, insulin growth like factor increases, leading to hyperandrogenism, and they are causing oligoovulation, hyperandrogenism, and PCOS on the ultrasound. This is a self-perpetuating cycle of insulin resistance in PCOS. There is peripheral insulin resistance, increased glucose, it goes to pancreas, increased insulin is produced, and this insulin is acting on theca cell, and increased androgen is produced, goes to liver, there is decreased sex hormone binding globulin, and increased free androgen. So it is a perpetuating cycle of insulin resistance. Insulin resistance, what it is? What do you mean by insulin resistance? Either there is decrease in the affinity of insulin receptor toward the insulin, or there is impaired signaling inside the cell, or there can be decrease in the number of insulin receptors. There is insulin signaling transduction pathways. There is a phosphorylation of serine and threonine residue in the insulin receptor, which reduces the signal transmission. So there is a problem with the signal transmission inside the cell. And you can measure insulin resistance by homoinsulin index. This is the formula how to measure the insulin resistance. It is being used commonly in our center. What is the impact of insulin resistance and impact of hyperinsulinemia and women PCOS? If you look at the picture there is reproductive failure because the hyperinsulinemia is acting on the brain. It is causing increased secretion of GnRH from the pituitary. From adrenal, it is causing increased ACTH. On ovary, it is causing increased LS. So all these lead to reproductive failure. Similarly, hyperinsulinemia is acting on the adipose tissue, skeletal muscle, and liver, and it is causing all the metabolic abnormalities from the hyperinsulinemia. Why do you want to use insulin sensitizer in PCOS? Because the insulin sensitizer will reduce the insulin resistance and hyperinsulinemia to mitigate the metabolic risk. It will lower the ovarian androgen production and improve sex hormone binding globulin level. It will restore the ovulatory cycle. It will enhance the response to ovulation induction and assist in reproduction. The lifestyle and insulin sensitizer lifestyle is the main thing. The first thing is lifestyle modification. You have calorie restriction and physical activity. That will always remain the first line of management. And weight loss of 5 to 10% specifically improve insulin sensitivity. Insulin sensitizer will augment, but they cannot replace lifestyle intervention. So you have to remember the lifestyle intervention has to be the first line of treatment. Weight reduction by 5 to 10% can be helpful. 30 to 50% of PCO are overweight, either BMI more than 24 or BMI more than 30. And weight loss will help in increasing the sex hormone binding globulin, and which cause decrease in free estrogen and free testosterone. It can decrease insulin level, causing decreased androgen, and peripheral aromatization androgen and estrogen also reduce. Insulin sensitizer in PCOS, the main classes which are available is biagonides, that is metformin, then thiazolidine derivatives like pioglitazone and rosiglitazone, then you have inositol, that is Myo-Inositol and DChiroInositol. And now we have emerging agents like GLP-1 receptor agonists and other with insulin sensitizing action. Metformin PCOS is being used for many years for reducing insulin resistance. Metformin has very good effect on peripheral tissue. But does it have effect on the ovaries? Probably no. It has effect on the liver, it has effect on the muscle fat, it has effect on the intestine. Ovary, whether it will change the androgen secretion, we still don't know. The role of metformin is to improve the insulin sensitivity and reduce serum androgen level. Action on the peripheral tissue irrespective of systemic involvement and metabolism and ovulative function. Metformin, the clinical application, the thing to remember is you have to be very sure that there is no kidney or liver function are normal and patient doesn't have congested heart failure. And inform the patient there is high likelihood that patient can have ovulatory cycle while taking metformin. The usual starting dose is 500 mg twice daily, but common side effects include nausea, vomiting, diarrhea, and metformin should be taken with meals. And patient who develop these adverse effects can be instructed to decrease the dosage to once a daily for 1 week, then gradually increase the dose. Thiazolidine derivatives, there is a binding of nuclear peroxisome proliferative activity receptor gamma to PPRE gene, that is the pioglitazone, which is 15 mg, and rosiglitazone 2 to 4 mg per day is being used. That is how it works. The fatty acid steal hypothesis is working, and it is causing increase in adenopectin and increasing insulin sensitivity. But there is a problem with this derivative. These receptors, this derivative pioglitazone and rosiglitazone are having limited use because of the weight gain, edema, and long-term safety. There is issue about long-term safety, the cardiovascular and bone issues are there. So because of the adverse effect, generally these are reserved for selected cases or generally in research context. We don't use them normally. Inositol in PCOS, inositol is polyalcohol and it is key messenger in insulin signaling pathways, and deficiency can be linked to insulin resistance. There are 9 forms available, and of which 2 are currently used in PCOS, Myo-Inositol and DChiroInositol. And both Myo-Inositol and DChiroInositol, they are acting like insulin-like action. Myo-Inositol is the most abundant form of inositol, and Myo-Inositol is converted to DChiroInositol by epimerase, and every organ has a specific Myo-Inositol versus DChiroInositol ratio that is linked to specific biological process controlled by each tissue. What are the difference between Myo-Inositol? Myo-Inositol is acting at the ovary. It increases glucose cell intake and normalizes the LH-FSH ratio. It increases oocyte quality. It reduces the amount of FSH used for IVF cycle. So basically, Myo-Inositol is improving the IVF result. DChiroInositol, it is acting at the peripheral tissue. It stimulates the glycogen synthesis, reduces the insulin resistance, increases the insulin sensitivity, and reduces the hyperinsulinemia. DChiroInositol doesn't have effect on the ovarian level. It reduces the risk of metabolic syndrome. There is a ovarian paradox that Polycystic Ovary Syndrome have an enhanced epimerase action which leads to conversion of Myo-Inositol to DChiroInositol, and it is responsible for the local deficiency of Myo-Inositol and leading to poor oocyte quality. That is what we generally face in PCOS patients. The oocyte quality is poor because there is deficiency of Myo-Inositol. In these conditions, glucose uptake and metabolism in oocyte and follicle cells are negatively affected, thereby compromising the oocyte quality that depends upon the availability of adequate amount of Myo-Inositol. The role of Myo-Inositol and DChiroInositol in PCOS, it improves insulin sensitivity, reduces circulating insulin, decreases ovarian androgen, improves ovarian function, and improves oocyte quality and regular menstrual cycle. Myo-Inositol is there in the follicular fluid. It plays a key role in nuclear and cytoplasmic oocyte development. Higher concentration of Myo-Inositol in follicular is the marker of good oocyte quality. Is the Myo-Inositol and DChiroInositol ratio, is it important? 40:1, this is generally what pharma companies are telling us, but that is not the universal ratio. The ratio varies from tissue to tissue. In ovary, in the healthy condition, it can be 100:1. In PCO, it is 0.2 versus 1. So rather than following a ratio which is not defined, it is always better to provide the therapeutic dose of each ingredient. The therapeutic dose of Myo-Inositol is 1 to 4 gram. And therapeutic dose of DChiroInositol is 300 to 600 milligram per day. What are the management options for PCOS with overweight or obesity? You can have a lifestyle modification, physical activity, psychological intervention. You can have 3 to 5% weight loss, or you can do for bariatric surgery, which will give you 25 to 30% weight loss. What about in between? The pharmacotherapy filling the gap, which can give us 15 to 20% weight loss. And for that, we are having multimodal approach to weight loss. First line is lifestyle modification. The second pharmacological therapy which has come recently is the GLP-1 glucose-like peptide 1 antagonist, semaglutide and tripizide, which is now available and approved for obesity management with metabolic and reproductive benefit. 2025 evidence, these agents improve the insulin sensitivity, they reduce the hyperaldosteronism, they lower the systemic inflammation, and this is all the advantage of GLP-1 agonist which is available to us. Bariatric surgery causing a use basically when the high BMI is very high, then we are using bariatric surgery. The GLP-1 agonist available is semaglutide, various brands are available, Ozempic, Wegovy, Polycystic or tripizide, a brand is available, Manzaro. GLP-1 is the causing reduced blood sugar, reduced appetite, reduced energy intake, and it has been developed for type 2 diabetes, and these are the various brands available to us right now. The other is Manzaro. Manzaro is a glucose-dependent insulinotropic polypeptide and a glucagon-like peptide 1 receptor agonist combined into two. When you are giving this Manzaro, you have to be very careful that the patient with medullary thyroid carcinoma, multiple endocrine neoplasia, or people who are allergic, they should not be given this Manzaro. The latest data about 2025 agonist in PCOS and ART, this semi-for trial in 2021-25 was conducted, semaglutide for fertility enhancement in obese patients, 280 women with PCOS with BMI more than 30. They received semaglutide 1 milligram per week for 16 weeks versus placebo. The group who received semaglutide, 28% improved ovulation rate, 34% increase in endometrial thickness, and 18% higher implantation rate. Then there was another trial published in Fertility Study 2024, Metformin with lifestyle optimization prior to ART, 400 obese women, BMI 30 to 40, scheduled for IVF. They received Metformin with structural lifestyle modification. The improved live birth rate of 41%, reduced gonadotropin dose, and few cycle cancellation. So even Metformin has a role in obese patients who are being put for ART. Then adipokine modulation trial, which is an early stage trial, is still awaiting the phase 2 trial, and it is will be published soon. We'll find the result of this trial. Clinical recommendation: GLP agonist for at least 3 months pre-ART in obese women, especially in women with PCOS with insulin resistance. You can do close monitoring, and during ovarian stimulation, you should avoid it, and you must have a 2-month washout period before you start ovarian stimulation. Finally, the guideline for PCOS, international guideline published in 2023, Metformin reduces risk of ovarian hyperstimulation, and Myo-Inositol implant supplementation can improve the oocyte quality. The metabolic priority, Metformin is the first line. Consider GLP-1 agonist in the severe obesity. Reproductive priority, normal BMI, Myo-Inositol D-Chiro-Inositol, and always integrate lifestyle contraception, counseling, and pregnancy planning as appropriate. Emerging therapies, newer GLP receptor agonist and agent. These agents are also targeting inflammation and oxidative stress and decupine MET imbalance. Thank you very much.
Thank you. Thank you so much to our speaker. May I please request our chairpersons to introduce our next speaker, and we'll take all the questions at the end. Thank you.